thank you to everybody for joining us today. I'm Dr. Gareth Williams, the Medigold Health's Medical Director. It's a pleasure that you can all join us today for our Prevention is Better Than Cure webinar, looking at why businesses should invest in workplace wellbeing and why it makes good sense for that. I'm joined by a couple of colleagues who I'll introduce in a minute. Yes, yes, I'm Dr. Gareth Williams. Just go through some housekeeping to start with. This webinar is being recorded and it will be available at a later date. I understand that you will be sent a link to the webinar if you've registered to join. There will be an opportunity as well for question and answers at the end. We will hopefully get through the majority of the questions, but we'll see what the demand is. And if we do fail to respond live on this webinar, then we will put together a sort of frequently FAQ, frequently asked questions type response and get back to you with answers to the questions that you may have raised. Yes, I'm Dr. Gareth Williams, Medical Director. I'm joined by my colleague, Dr. Kent Haworth, Consultant Occupational Health Physician here at Medigold Health as well. Kent will do the majority of the presentation from a clinical point of view, covering and discussing how investing in employee health and well-being can help you as a business. I'm also pleased to say that I'm joined by Steve Thompson MBE. Steve has recently joined Medigold Health as our new health awareness campaigner. Several of you may know Steve from his previous professional rugby career, very successful, if I may say, as a England World Cup winner back in 2003, and also a British and Irish Lions. Yes, so that's the general introductions. I think we can swiftly move on now for Kent, who will cover the occupational health landscape as it is. Looking at what good occupational health provision looks like. There have been several recent guidance documents and reviews produced by the government and also Society of Occupational Health, looking at health is everyone's business. Also looking at the sort of risks and the benefits of having a good occupational health provision for your organisation, and some of the consequences of not having that provision, and reviewing why you should consider investing in good occupational health, and realising that it is there is a cost benefit to it. Steve then will join Kent later on and present his own experiences of workplace health and the consequences of, in effect, poor occupational health input and support. So I'm now going to swiftly pass you on to Kent, who will present the background to all of this. Thank you.
Thanks, Gareth, and good afternoon to everybody. I'm delighted to be able to lead this webinar today with Gareth and Steve. And first of all, thanks to Nicole and her team for bringing it together and producing this marvelous slide pack. I've got about 20 minutes to rattle through my slides. It's going to be a very top level bird's eye overview of all the headings that you saw on the previous slide, and I'm really looking forward to any questions that you may have, and we'll do our best to answer them. So very swiftly then, I would like to just paint a brief picture of the occupational health landscape as it has appeared, trying to draw upon the most recent statistics that we have. And the next few slides are going to illustrate some of what I regard as some of the more interesting statistics that came from a July 2019 government statistics paper, which contributed to the comprehensive evidence base supporting the work and health consultation, Health is Everyone's Business, which I'm sure some, if not all of you, have heard about. So just to give you some idea of the scale, over 100,000 people, and this is 2019 numbers, leave or left work following a spell of long term, which is defined as more than 4 weeks absence each year. And just drilling down into that headline a little further, long-term sickness absence, 1 in 25 employees had a spell of such in the last 12 months. And as we all know, the longer the long-term sickness absence, the less likely the employee will return to work. Of those who did return to work, the vast majority had a spell lasting less than 6 months, and a small minority had a spell lasting over a year. Unsurprisingly, mental health and musculoskeletal were the most common conditions. Just looking a little further into that data, gender differences, 5.2% of women had at least one spell of LTSA in the last 12 months compared to 3.7% of men. The likelihood of LTSA increased with age, and the older groups, 55 to 64 age groups, were 3 times as likely to have a spell of at least one LTSA compared to those under 25. There's also data on ethnicity, but I just want to focus a little bit on disability, just to highlight that, of course, disabled people face greater challenges maintaining employment than non-disabled people, and that disabled people were 5 times more likely to have a spell of LTSA than non-disabled people. Numbers rising to 15% of disabled people having at least one spell of LTSA in the last 12 months compared to 3% of non-disabled. So it's something to think about there. Workplace size, employees from large organizations defined as 250 plus employees were 1.5 times more likely to have LTSA compared to small employers defined as having between 2 and 49 employees. And that gives rise to 1 or 2 considerations. Why are we seeing that difference? Is it because employers from the larger organizations feel more supported and more able to take long-term sickness compared to those from smaller employers who may not have the means or the support mechanisms to sustain their employment and eventual return to work? Access to occupational health. Senior employees are significantly more likely to have access to occupational health services, and professionals twice as likely to have access compared to elementary occupations, which are defined as jobs which involve mostly routine tasks, often involving the use of simple handheld tools, and in some cases, a significant degree of physical effort. Full-time employees more likely to have access compared to part-time, and the age groups 35 to 59 most likely to have access, with those younger and older age groupings least likely. So against that statistical backdrop, what does good occupational health look like? Now, there are many, many definitions of what occupational health is, but the one I sign up to is the first bullet there, occupational health being primarily concerned with understanding and optimizing that interrelationship, that crucial interrelationship between work and health, and how one affects the other, hopefully in a positive or positive way, but also in a neutral or negative way. Occupational health or occupational medicine is a hugely broad specialty, but the key thing is that it's relevant to every worker in every workplace and in every organization. Its purpose is to support employers in meeting their legal and moral obligation to protect workers, and therefore also protecting workers, if that is completed, through the effective control of workplace hazards in whatever form they come, physical, physiological, or psychosocial. In other words, it aims to minimize the likelihood or risk of preventable ill health occurring. And once all mechanisms are in place, then it should serve to promote, optimize, and maintain health at work, and by extension, outside work. And this includes effective rehabilitation of injured or ill workers in tailored return to work programs, and we'll come on to that a little bit later on. Key motivations for employers to engage in occupational health are legal, moral, and financial concerns. So inevitably, this ideal, this utopian ideal, isn't always realized, and in some situations, the risk of harm from work may outweigh its benefits. And when it does, managers supported by their occupational health and health, safety, and environment teams have a critical role to play in optimizing workplace conditions and implementing change or implementing provision of occupational health and realizing the benefits. And this is a crucial point. It demands senior management-led approach across all key stakeholder domains. We all know that work is generally good for you, but it has to be the right type of work in terms of its quality, nature, and social content. Moving on a little bit, how does occupational health help in terms of communicating outcomes? My view is that clear, focused, and timely communication between all key stakeholders, workers, and occupational health teams using contextualized language that all parties will understand is an absolute key component to success. It helps promote shared understanding, and once this is reached, hopefully from the outset, and expectations are suitably managed in terms of what occupational health can and cannot do, we can assist the employer and employee, particularly in management referral cases, to move things along. So we spoke about adjustments, and we're going to come on to this again a little bit further, but one of the key things that occupational health can do is recommend adjustments and return to work, particularly those, as we highlighted earlier, who've been on long-term sickness absence, the majority of whom return before 6 months, certainly before a year. Their return to work can often be expedited if the employer introduces reasonable adjustments, only if necessary and if justified. Now, what is reasonable is not for occupational health to decide, it's for employers, but some examples can include permanent or temporary adjustments to working hours, content structure, all the way down to reallocation of duties and everything in between. So adjustments are designed to remove obstacles that employment would otherwise place disabled workers or people who have been unwell at a significant disadvantage compared to able-bodied or otherwise fully healthy workers. What exactly defines a reasonable adjustment, of course, is dependent upon the specific circumstances of the case. But the key message here is that most adjustments are uncomplicated and undemanding to implement. But of course, that is not always the case. Occupational health standards, depending on organizational need, the full range of professional occupational health service functions should be delivered in accordance with accepted core standards. Some of you may have heard about Safe, Effective, Quality Occupational Health Standards, which is an organization that sets out to outline and help organizations continually improve their standards of OH provision across a number of domains, from business probity to facilities and equipment, people, and relationships with workers. Now, I want to very briefly talk about two government publications. The first being the Health is Everyone's Business proposal, which was published in July 2019. It was a green paper presented to Parliament by the Secretary for Work and Pensions. It outlines what needed to change, presented a clear legal framework for employers to deliver the recommended changes. It also espoused occupational health market reform and suggested that advice and support for employers was well overdue. And it signaled to me that there was realization that in support of the Society of Occupational Health's Occupational Medicine's letter to the HSC chair and CEO calling for universal access, occupational health access in March 2021, March last year, chiming with that, it indicated a realization that universal access to occupational health was becoming more and more important and was gaining traction at government level. It seemed to me that occupational health and its provision was rapidly becoming the tallest pole in the tent, and that there seemed to be much optimism about the government's support for universal access to occupational health. Now, of course, every proposal invites a response, and in July 2021, the government did exactly that in its response. And I just want to focus on a couple of chapters here. It is a long, it's a very detailed document. Helpfully, each chapter has a sort of a mini executive summary, and I'd suggest that anybody who wants to know more about the subject goes to the source document. And I should say that all the documents I've referred to this afternoon are listed in the reference at the end of this reference section at the end of this presentation. So I want to focus on chapter 2 and chapter 4. Chapter 2 focus on helping employers improve support to employees during sickness, absence, and return to work. And I'm not going to read out the bullets there, but I just want to pick out that it understood the importance of workplace adjustments, and we spoke about that in a few slides back. But it also was keen to ensure that existing protections, statutory protections, and other protections were maintained. There were concerns around awareness and understanding of compliance with legislation, and so the government undertook to try and improve the messaging and support to employers looking for such information. So as I mentioned, that lack of awareness and understanding was recognized, and the government intended to do, or intends to do, something about it by supporting organizations such as the Equality Advisory and Support Service and Access to Work, which I'm sure you're both you're familiar, very familiar with both of those. Chapter 4 focused on helping employees access quality occupational health support. And in summary, without going through all of those bullets in detail, it was shining, it recognized the need to shine a light on what looks and is good in occupational health. It outlined the steps the government were taking to enable SMEs, small and medium-sized enterprises, and self-employed people to reap the benefits of expert health and work support, including occupational health. More accessible occupational health services may lead to a rise in demand, and potential new customers of occupational health will require support to ensure they are not purchasing inappropriate or low value services. That is a very key point in my view. Occupational health services need to be bespoke to the organization. Off-the-shelf solutions rarely provide the results that would otherwise have been desirable. So it addresses concerns about shortages in the occupational health workforce. It discusses methods to promote the expansion of clinical roles to improve accessibility, capability. And it talks about occupational health multidisciplinary workforce models, developing new training approaches, and establishing an occupational health leadership function to help drive the occupational health workforce strategy forward in order to support delivery. So moving on then, what are the possible consequences of no or suboptimal occupational health provision? So a few more statistics here, and I'm going to focus on mental health. There are, of course, other, excuse me, other clinical domains to think about, but mental health and musculoskeletal health are the key issues here. So let's, for the moment, just focus on mental health. In 2021, there were 822,000 workers were affected by work-related stress or depression. So that is equivalent to almost 2,500 per 100,000 workers. And the cost of that in terms of poor mental health well-being to the government, including NHS costs, etc., was estimated to be between 24 and 27 billion pounds. And the lost output to the economy, a staggering 74 to 99 billion. And that was based on the document called Thriving at Work, which was published in 2017, otherwise known as the Stephen Thompson Review of Mental Health and Employers. Again, the references are given in the final section. Mental well-being at work also, the national the sort of NICE guidelines also produced something very recently, and I would urge everybody with an interest, the target audience being employers, senior leadership and managers, to look at this document, which was published only in the last few weeks, the 2nd of March. It applies to micro, small, medium-sized and large organizations equally, and it espouses proactively promoting mental well-being and ensuring that it is embedded in overall business strategy of all organizational policies. So I just a shout out for that document. And we've seen these stats before. Interestingly, Deloitte reported an increase of about 6 billion and 16% on their figures in their 2017 report of the costs of poor mental well-being, and that was driven primarily by a rise in presenteeism. So a few more definitions here. What is presenteeism? I'm sure you will all know and possibly recognize in yourselves or co-workers that it occurs when people work when they are in suboptimal health, i.e. working when ill. Just a brief word here on leavism, and this is a new phenomenon, or maybe not a new phenomenon, but the phrase has been coined, or the term has been coined recently, and it's where people work outside of their contracted hours or using annual leave to work when ill. Average, I just also would like to draw your attention to another document published by the Society of Occupational Medicine, a very topical, presenteeism during the COVID-19 pandemic, risk factors and solutions for employers. Again, references at the end of this slide pack. It points out that average employee in the UK spends 2 weeks a year working while ill. Presenteeism, of course, can be positive. It can expose people to structure, building confidence, and so on. And in some ways, it should be embraced, but in a very controlled and measured way. But more often, my view is that it can be negative. It can delay recovery and increase risks of problems down the line, not least from an organizational perspective, reducing productivity. Both need to be carefully managed, and a phased return to work is a subset of presenteeism, but it is phased returns to work with the correct advice. It can be a very positive thing, and it is something that is regularly recommended by occupational health. Risk factors for presenteeism are personal, organizational, and occupational, and you can read those for yourselves. But what can be done at organizational level? Assess the risks, identify the problems, carry out well-being surveys, establish cultural norms. All of these things can highlight and mitigate this phenomenon. So last section now. Why should occupational health be seen as an investment and not a cost? I draw your attention to two very important documents in the occupational health domain. The first was published in May 2017, and the second follow-up document to the first was only launched yesterday, and it's called Occupational Health, the Value Proposition. And this is, again, the links to these documents are contained at the end. These are Society of Occupational Medicine documents. Principal authors were Dr. Paul Nicholson, OBE. Why do we need occupational health? Well, we all know it enhances performance and it ensures regulatory and policy compliance. But it must be affordable and it must be cost effective. It manifests in tangible and intangible benefits. But the important thing here is that I think we are now settled in our view that economic analyses do not provide a sound rationale to invest in OH, and return on investment as a concept doesn't really work when considering the purchasing occupational health services. We need to have a different view to this because the quality of research is somewhat lacking in the ROI area. Imperatives are financial, legal, and moral, but it's worth pointing out that highly effective companies commit to a culture of health through good workplaces, employee engagement, and well-being and productivity recognized to be interrelated. It should be regarded as an investment and not a costly outlay. Direct costs for poor occupational health include elements such as restricted duties, sick pay, legal costs potentially, indirect costs, overtime cover, recruitment fees, training of replacements, and intangible costs, presenteeism, as we've discussed, lost productivity, poor engagement, and so on. So access to occupational health, as we heard right at the start of this presentation, only a minority of the UK workforce can currently access occupational health. Depending on your definition of occupational health, highlighting the challenges in the literature here in terms of quality and comparability of studies, suggests that between 3 and 13% of employers provided access to occupational health. Now, if SMEs account for almost all of the UK private sector businesses employing 16 million people, that translates into 38 to 59% of employers being covered by OH nationally. The public sector access was greater than private sector access, just as an observation. So the burden of sickness absence, just a few more stats. 2013, 113 million days were lost due to sickness absence, and the cost to the UK economy there being almost 30 billion per year. The business case, it makes good financial sense, it makes good legal sense, and most importantly, in my view, there is a very strong moral imperative, moral case for providing swept up occupational health services for employees. The evidence of benefit, where it does exist, there are some good quality studies, but we spoke earlier about how many people were on long-term sickness absence and how return to work using adjustments and phased returns was formed a mainstay of occupational health advice. Return to work and disability management, there is strong evidence of an economic benefit from occupational health involvement in these areas. Musculoskeletal, strong evidence of economic benefit, of musculoskeletal evidence in manufacturing and warehousing industries. Common mental health disorders, a study performed on nurses regarded as a stressful, in stressful roles, showed that absenteeism and presenteeism were reduced significantly in an intervention group receiving personal feedback and an OH physician, OHP input compared to those who didn't. Targeting programs towards groups at risk and is likely to optimize efficiency and minimize costs of expensive occupational health resources. And this swings back to my suggestion, or my observation from the government papers, that occupational health needs to be targeted to the individual needs of the organization and employment sector. So that is a canter through the current landscape, and a very, very top level view of how those in occupational health feel that we can contribute to to supporting businesses who are forward-leaning in terms of their approach to occupational health. And I'd be very happy to take any questions at the end. But what I'd like to do now is hand over to Steve for his case study. Over to you, Steve.
Hold on a moment, Steve. We can't seem to hear you.
Sorry, there we go. Sorry, good afternoon, everybody. Sorry, I didn't want to, with my breathing and stuff, I wanted to mute the mic. Sorry about that. Good afternoon, everyone. I'll go over quickly about my work life in my previous life. I was a professional rugby for 15 years. As I said, I've won the World Cup with England in 2003, played for the British Lions in 2005, played for Northampton, and also I played in France with Brive. So I've managed to travel around the world a lot as well, New Zealand, Australia, Canada, America. But what's happened since, once I retired from rugby with a broken neck in 2011, I moved to Dubai, where I met my wife then, and we started a family fairly soon. Went back into the construction world, which I was involved in before that. And then in 2014, life was going well, it seemed. Children early, just going into private school, house being paid for, working really well. Towards the end of 2014, I started missing meetings. I started forgetting what was happening in meetings, coming out confused. And then gradually over the next probably two years, it just got worse and worse and worse. But I just thought at that time it was down to age. And when you look at that, I would have been late 30s, as I'm 43 now. And then, to be honest, I had a breakdown. Literally just fell apart out of nowhere in 2018. So being in Dubai, you have to work to get a visa to live there. All of a sudden, my family, I had a young family, my wife, my children, we had to leave Dubai literally within a month. We moved to Cyprus, where I sat in the garden for about 15 months, contemplating why I wanted to be on this earth, in tears, trying to be a dad, trying to find a way of how I was going to work, because I didn't know what was going on with me, what was happening. Being on my own out there was quite scary. So we made another family decision of moving back to the UK, where just at that time, COVID started hitting. And I managed to get a job working in the water industry, in the big aqueducts. So I went from being a director of a company owned by Emirates over in Dubai to digging holes, which, to be honest, made me the happiest I've been, my wife said. But then, strangely enough, problems sort of caught up with me. I'd be 100 meters away from the van, walking back to get some tools, get there, suddenly I wouldn't have a clue what was going on, what tools I needed. I'd come back, suddenly I was confused again. And then I got a phone call from an old friend of mine, a colleague that I played in France with, Alex Popham, and he started to discuss with me what was going on, about himself. He said, and the biggest thing was he'd gone back to where he was brought up in Wales, and he'd be out on his push bike and suddenly he'd just totally lose where he was, wouldn't understand. He got picked up by a neighbour, didn't really know who they were. He was totally, and suddenly when he was explaining all this, what was happening to him, I just thought to myself, really, you're telling me what's happening to me. So he said, why don't you go and get tested? We can go and get the scans now with DTI. You can see the specialists. And obviously because of COVID, this took a lot longer. So it probably took about 6 to 7 months. And then I was diagnosed with early onset dementia and probable CTE. And this was down to the rugby. This is what we're looking into at the moment. It's down to the rugby, because it's not about the big concussions and the big head injuries and the big, when you're knocked unconscious, they call them sub-concussions. And when they went through, when the game first went professional in '96, it was like the Wild West. So we were training contact 4 hours a day, 3 to 4 days a week. And then we were doing other contact sessions as well, plus the game on top. Was there evidence of this out there, of punch drunk syndrome? Yes, there was, since the early 19th century. So when you look at this, did they do their homework, the authorities and that? We believe that they haven't. Did they have a duty of care to us? Yes, they did. So when they've looked back, they think I've probably had about 80,000 to 100,000 sub-concussions. And over that time, the small knocking of the brain onto the skull and that has caused areas of the brain to die. So I've had a significant brain damage, which I try to look at, rather than looking at early onset dementia, I see it as a brain injury. So I can cope with it more and I can understand that I'm fighting something. What has that caused? The symptoms, like I said, memory loss, massive memory loss, where, going into meetings, coming out, just nothing's there whatsoever. So I'd say I love my reading. So I've been reading the same book for 8 months now, whereas before I was reading the book and it was 2-3 days, 4 days. Now I'm on the spot. I'm determined to finish the book. But what was happening at first, I'd read a chapter at night, 2 chapters. Suddenly, next day, pick the book up, and it was like I was picking the book up from afresh again. But then I found that quite tiring and quite upsetting. So now I just carry on from the page that I'd finished the night before, even if I don't understand exactly what's going on in the story. Anxiety at times. I used to be outgoing, used to be have to look after customers, be out there socializing. That's a real work on at the moment for me, because I've just gone into my shell, moving out. I'll be honest, lost a lot of respect for myself as well. When you've got young children and suddenly you find it really hard when you're tired to even take them to the shops. you know, I've got 4 children under 9, and I feel that, you know, I want to be a good dad, but then I need to know what's going on with me, and I need to get myself ready for that. The highs and lows are massively. So for me, a big step at the moment is I am looking at going on some medication to level me out, because the highs I find are a lot worse than the lows, believe it or not, because when I'm high, I organize so much to go on, then suddenly I know that when I hit a low, I need to counsel them, which upsets me even more and tires me. So, you know, for me, it's just understanding what's going on. Part of the case that's happened 15 months ago, there was 3 of us. Now there's just under 300 that have been tested and diagnosed with this problem. And people say, yeah, that's professional sport, but it's not. This is from the amateur sport as well. So this is a big problem that we need to understand and look at. How can we get people working, understand it early? Like at the moment, to me, it's ski season. So this is a simple one. How many people are out there skiing, suddenly they bump their head, they don't feel like they've been knocked unconscious, they just carry on, suddenly they come back, and their day-to-day living just starts to be affected quite in little ways, and then all of a sudden there's a big character change in there. But if they know they've had this brain injury and everyone talks about it, we can understand it, and there are ways to get around it. There is ways to look at the inflammation on the brain, and to get help for yourself. Like I said, for me, because I've had that diagnosis, I've spoken to the neuropsychiatrist, who explained it to me and said, your brain is like a Nokia battery, but an old one, but in a younger body. You know, I've worked as hard as I can. As soon as I got diagnosis, I lost 25 kilos in about 2 months, because it's like, I've got to be fit. This is the big thing. Change my diet, change the habits, all the little things you can do, I've done. So with this Nokia battery thing is, I was emptying myself out all the time and trying to do too much. And then in the end, I'd fall apart. And I must admit, I'd be in my room, headaches, just falling asleep, in tears, just not understanding what's going on. Whereas now I've had to change my whole routine. So, you know, even doing this now, you know, afterwards I'll have to go and have a rest, sleep, just calm down tonight, and then my children tomorrow will get, you know, a better day and a better dad. But then also that I can't work back to back, so my working opportunities obviously have gone shrunk significantly. So how many other people are there that have got this, that are emptying this out, that don't understand? You know, Dr. Kent earlier talked about the mental health. How many people with these mental health issues might have a brain injury? And for me, what opened my eyes massively is, once I knew I had, you know, people at first said to me, oh, you've got mental health issues, this is the problem. But for me, there was nothing to actually battle, and it sounds awful, there was nothing to blame. Once I was diagnosed and I could see the brain damage and I could have the diagnosis, for me, that was something to battle. That was something to go against, and something to say, right, it's that fault, but I can come back from this. And then you understand what's going on. So that's the massive thing for me, why I've got involved with Medigold, is because we want to be out there and raise awareness of what's going on. You know, like I said, in the small part of rugby players, there's 300 over 15-month period. How many other people are out there, and it sounds awful, domestic violence we're finding, ex-servicemen, people like this that are in the workplace that don't understand what they're going through, plus their family around them. So, you know, for us to get the understanding out there is massive, and it's helped me. You know, simple thing for a family life over Christmas, and this sounds silly, with young children, we opened all the presents on Christmas Day, first thing in the morning, and normally I'd cook a big dinner, but then I would have fallen apart in the previous years when I didn't know. So what we done, we had just small nibbles and everything all day. A great family day. Then the next day, the children were allowed to go on their tablets. I cooked a great dinner. So we had 2 great days, but it's all about managing your time and managing your energy rather than emptying yourself out. And, you know, that's come over the last couple of months, literally because of that. Since 2014, my life has just been so up and down, but I've been able to manage it more and get more out of life. And then obviously more working opportunities, and I can be back at work with these little, you know, like I said, the Nokia battery thing. And I'm learning more and more. And there's so many people now that we're able to get in contact with, and they can turn around and say, right, yeah, actually, you know, there they were at school. They had a serious car accident when they were younger. They've had head trauma. They've thought they've got on with their life, and all of a sudden this is happening to them now. So we can understand what we're up against, and we can understand that there's, you know, opportunities to make yourself better through health, through understanding and awareness. So, you know, for me, the impacts on the work was terrible. You know, like I said, I've gone from a boardroom job down onto the tools, which is great because I can talk to all type of people. But on the other hand, now my work life with CTE, with probable CTE, in 5 years, I could be in a home. Hopefully not. I'm trying to do everything I can. My feeling and the thought I always put out there is I want my children to come and see me. I don't want them to have to come and see me. So that's why I'm fighting what I can to be the best I can at the moment and stay fit and help other people as well. And, you know, for me, there's nothing better to get more people that I've spoken to. And then 2-3 months down the line, when I speak to them about the Nokia battery, about the diet, about, you know, work opportunities that they can do, because people are very scared to come out when they've got a job. Because I went out to the media 15 months ago, I openly said, in my 20s, all my playing career, my World Cup British Lions, I have no recollection of that whatsoever. I can't remember being in Australia, in New Zealand. So I've lost the opportunity to work, to do dinners, to talk to people, to go out there and talk about rugby. And then also because of that, I couldn't work on the sites, because if someone else got injured, they could quite easily turn around and say, well, actually, he's on site, it's his fault. I could say, well, no, it wasn't. And they'll say, well, how can you remember? You've got dementia. So it's a way of, you know, you've got to know in roles and responsibilities what you can do in the workplace. And what we're trying to do is come together with work agencies and come up with roles that people can do, because there's nothing worse than having a mental health stroke brain injury and then have no respect for yourself, because I'm a worker, I love working, and that's what I like doing. And when that's taken away from you, there's nothing else to go for. Whereas if we can give the opportunities and find ways of getting people back into the workplace and having a bit more respect for themselves, because that's what's happened to me over the last few months, you know, especially with getting this role now, it's given me another way of living and another reason for living. So, you know, like I said, you know, there's hope out there, and it's just the understanding, the awareness now that we're really trying to raise. And I really think, you know, this is huge, and it's just getting worse. And it's not just obviously Britain, it's going around the world, what's going on. So we just really want to raise the awareness and the understanding and come up with the tools to help people, you know, the family around them as well. I call it the hand grenade. You know, when I finally do go, my mind goes, it's not me, it's my wife and it's my children that are going to have to look after me. But through health, well-being, hopefully that's going to be a lot longer. And also having the understanding now, we can try and catch this earlier and help a lot more people and have a lot more time. So yeah, thanks very much for your time, and I appreciate that. And obviously, if there's any questions now, I think, are we okay, Dr. Gareth, Dr. Kent, to open that up?
Yeah. Thanks very much, Steve, for that.
Thank you, Steve.
Yes. I may have forgotten at the start to mention there's a Q&A button at the bottom. If you want to ask questions, please type something in on there. it's interesting when you mention, Steve, your current difficulties and things like that. And what's important is looking at the adjustments, that it ties in with what Kent was saying about reasonable adjustments and employers looking at what people, concentrating on what people can do. That's the important thing as far as I'm concerned. I don't know whether, Kent, you want to add anything on to that?
Yeah, no, Steve, thank you for that. It was really fascinating and really encouraging as well. I can't I'm a cold-face occupational physician. I take management referrals. I do a few other things, but one of the things that one of the things I think we can help employers help employees and help employees help themselves is through sensible recommendations for adjustments and signposting to organizations where there is more information available. We're not going to get it right, every time, each time, every time. But if we move together with supportive management, and it's all about the organization being willing to engage with the individual, and the very fact that they engage with occupational health and well-being shows that they are that type of good employer, in my view. If we can all work together, communicate and understand and do what is within the art of the possible, recognizing that the vast majority of adjustments are simple and affordable and straightforward to implement. If we can all work together towards that goal, then the lot of employees will be better, and the organization will hopefully find itself in an upward spiral in terms of its moral obligation towards its employees. But fascinating what you said, Steve. Thank you for sharing that.
Yeah, some interesting feedback as well, Steve. Just acknowledging what your brave story. Somebody said thanks very much for sharing your brave story. Powerful. Thank you for sharing this, Steve. Your honesty is much appreciated. Interestingly, one comment about a healthcare worker on acute medical ward, and mental health issues still quite a social taboo even in this day and age. And I agree with the comment made. There's a lot of work to be done in supporting individuals with mental health issues in the workplace. There are great organisations out there like Mind and people like that, and even in the sphere of head injuries, Headway and people like that out there who do offer a considerable amount of support. So there is there is support out there, but I think occupational health fits in by providing the employer with advice and support as well as the individual. They're general comments at the moment. So everybody's appreciative of your story, Steve, and I think we all wish you well on your journey.
Thank you very much. Thank you.
Yeah.
We have had some questions as well. So thank you, and thank you to the panel. I'll just read out a couple of the questions. I think one's perhaps aimed towards Kent. Early on in your presentation, you mentioned about sort of long-term sickness absence is higher in larger organisations. Jill Kay has asked, do you think this is down to the fact that there's sick pay?
Well, sorry, was that was the question? No, I didn't interrupt you. No, who knows? It's lies, damn lies, and statistics. You can make it. You can make it. These figures, satisfy any story. But I think one of the challenges is extrapolating these statistics to every organization. Studies from the US or from Finland or from Japan don't necessarily translate into the UK experience, or even the experience in small organizations, medium, organizations or large organizations. But my sense is that if an organization is has the means, and that is both sort of financial and managerial to support people who require a long period away from work, then it's likely to be the larger organizations who have more financial welly, I suppose, to do that. But also perhaps the smaller organizations who, and cost is a significant consideration when it comes to buying occupational health, and the government are looking at this. So I'd urge you to have a look at the government's response to Health is Everyone's Business for more detail. But it may well be that organizations who would otherwise want to keep somebody, want to support them, want to see them back in the workplace, simply can't afford it. So these people possibly fall out of employment and skew the statistics. But who knows? But I suspect you're on the right track there when it comes to the difference between the larger and smaller organizations.
Okay, thank you, Kent. Steve, a question for you actually. Thank you for being so honest in your account. What are some of your general coping mechanisms for your mental health?
It's trying to, like I said, get ahead of the game as such. Like for me now, because I know I've got it, like I said, it's the resting, it's the understanding, it's having the time to myself. It's like the travel anxiety now. I'm having to go to London a lot. I'm having to travel a lot. I look a bit weird because I end up going around with big headphones all the time, but it's just being able to get steps in. At the moment, I tend to get quite confused on trains. So a number of times I've stood up and run off the train at a station and it's nowhere near where I need to get off. So it's all getting understanding now. So I write down, or I have a photo on my phone of all the stops that I'm going to not get off at. So if I look up and panic, and it sounds really weird talking about it because it used to be such an easy thing to do. So it's because it's so new, I'm having to put the steps in place to make sure that less of these things happen more regularly. But the biggest thing is understanding and resting. For me is getting that rest and not backing up a busy day with another busy day because you want to try and make someone happy. That sounds awful, but it's true. You know, if people want, and I hate saying this, like the best me, they can't expect me to be like that every day. I've got to be able to rest, get ready, and then do it. And saying no is a lot stronger than saying yes, if I'm honest, at the moment. And that's what I do. It's a lot of quiet time. Like I said, I've got 4 young children, which is quite hard at times. And, you know, they're very understanding considering how young they are. So for me, it's getting the rest is the best part when I can.
Okay, fantastic. Thanks, Steve. Just time for one more, I think, before the end. Somebody said, thank you, Kent. Really interesting statistics with some of those alarming figures. Do you think OH will ever be a mandatory requirement for businesses? Here's hoping.
Well, here's hoping, and I think again that's what the government are moving towards. Universal access, the Society's letter, I referenced that in the presentation from 2021, came off the back of the government's response, or you know, it went hand in hand with that. One would hope, and it has oft been said that possibly the NHS missed a trick at its inception in not including occupational health as part of its offer. So look, we are where we are. It's looking good for occupational health in terms of the government support. What we need to do as providers and commissioners of our services is shine a light on what on how to optimize the benefits, how to get as much benefit for employers as possible, and I hope making it an integral part of what we see on a day-to-day basis across all sectors. I hope that becomes a reality one day.
I think that's a great note to close on, probably.
Yeah, thanks very much, Kent and Steve, for joining us today, and I hope everybody found that useful. As I mentioned at the beginning, the recording will be available and you will be sent a link to it. Thanks everybody for joining us today, and have a good afternoon. Thank you.
Thank you.
Thank you.
Thanks,
Thank you very
everyone.
much.
Bye.
Bye-bye.
Bye bye.